Hey everyone, my name is Dr. Saad Hanan, and I've got with me Dr. Kiran Nizamani.
Hi.
And we are going to be going over a very interesting topic today, one that is close to many of us because of how often we see it in the clinical setting.
Yeah, I
Right?
thought you were going to say something different, close to many of us.
Oh, no, I mean, we do see often a lot of
Yeah.
students who, patients
Yeah.
with this problem and this concern. So
Yeah.
one thing that I want to address is when we go through this question, I think maybe one of the ways how you would go through
Sure. Yeah.
trying to figure out what type of anemia it is,
Mhm.
maybe give us some suggestions as to
Sure.
what you will look at. So I'll go ahead and read the question, and
Okay.
you provide any guidance that you can. So
Sounds great.
a 24-year-old woman recently emigrated to the US from Indonesia, coming to the clinic to discuss with you in terms of her fatigue. Yeah, please, could you? I cannot see that part. Constant fatigue. So she states over the past 6 months, she has been feeling extremely tired and unable to stay awake at work, even after drinking multiple cups of coffee.
Hence the couch photo.
She denies loss of consciousness or dizziness. She reports of heavy menstruation due to her fibroids. So we could see some laboratory results. Our hemoglobin is a 10.2 grams per deciliter, it's kind of low. 32% is our hematocrit, also relatively low. White blood count, it's at the lower end, but not so much. And the MCV value is at 70, so that's kind of low as well. So out of all of that, what do you think is the most likely explanation for this patient's symptoms? So before you go ahead and answer it, I just want you to discuss how would you work this question?
Sure. Yeah. So it's interesting. My style of reading a question also, I always read the last line first. So just trying to keep the what I'm going to focus on in the question in mind. I know everyone has their own style. So for instance, for me, it'll be like, what is the most likely explanation for this patient's symptoms? So I know what I'm looking for in a sense. So with that in mind, I'm looking at, okay, somebody, she's a woman who's of childbearing age, right? So she goes through menstruation, which is something that she talks about, right? Exactly. And so she has heavy menstruation, and that's a monthly occurrence, right? She faces fatigue. That's something that I would highlight, absolutely, which makes her feel also tired. No matter how much coffee she drinks, it doesn't work in her favor. Okay.
And that's important because we all drink coffee, and you know how much energy that gives.
Also you crash.
Oh yeah.
I definitely crash. Now I know. And then, just the lab values we've highlighted here, I think those are very important to focus on, right? Because you're looking at somebody, as soon as it mentions like blood loss, that's something that is mentioned, you want to consider what is being lost, right? So red blood cells, but what else is there, right?
Gotcha.
So the hemoglobin is low, right? MCV is low. So the normal range would be what? 80 to 100.
Exactly.
Right. So lower than that, I would classify that to be microcytic anemia. Greater than 100, I would classify that to be macrocytic anemia.
Okay.
Yeah. Right. And then in the microcytic anemia, we have subheadings, and in macrocytic anemia, we have subheadings. There's also normocytic anemia. Okay. And there are different types of anemias that can fit into that. And so what is the most likely explanation for this patient's symptoms? So if I'm reading answers, if you want to go ahead.
Yeah, it's A for hemolytic anemia, B for normal response, C narcolepsy, D iron deficiency anemia, or E B12 deficiency.
Right. And if I'm looking at all these options, they could somehow fit into the picture.
Yeah.
But when approaching a question, especially for step 1, I'm thinking, what's the most common cause?
Yes, exactly.
Right? That's the most common cause that they're going to test us on. They're not going to necessarily test us on the third most common cause until and unless they give us an indicator of why that's the case. So if I'm looking at the most common cause of why the patient is facing such, I'm generally going to cancel out narcolepsy. They didn't give me any lab values that fit into that. Right? Normal response, that doesn't seem like a normal response, right? 24-year-old woman being constantly fatigued. You're thinking something is wrong, something is deficient, or something is autoimmune. Right? So B, I'd cancel out as well.
Okay.
Hemolytic anemia, it's also a great possibility. However, in the case of hemolytic anemia, generally they would give us a reticulocyte count. Which they did not. Reticulocyte count is what? It's basically our bone marrow telling us whether we are producing new red blood cells, immature red blood cells. Now, in hemolytic anemia, hemolytic means what? Something is lysing the red blood cells. So if your red blood cells are being broken apart
Yeah.
and they're not being used properly, your bone marrow will go ahead and produce more to compensate.
Yeah.
They don't give us that.
Nope.
Right. And then we have B12 deficiency. B12 deficiency generally would fit into the macrocytic anemia category.
Yeah.
So the only answer option that I've left now is iron deficiency anemia.
All right. I think you're 100% correct. So yeah, you discussed something very important. You said you look at the hemoglobin values, you looked at the lab values, and that gave you a general sense of where things are. And you said something about reticulocyte count, which is very important to see if new red blood cells are being formed. And obviously in this situation, they've given us hemoglobin and hematocrit, and they gave us an MCV value, which they kind of wanted us to, look around, maybe trying to figure out what type of anemia it was. And normal hemoglobin levels for females is obviously 12.6 to 16. And as for a male is 13.5 to 17.5. And the hematocrit, obviously 36 to 46% for females and 41 to 53 for a male. So based off of those lab values for a normal individual, obviously seeing our patient definitely looks like they are anemic.
Exactly.
And, as you said, with dysmenorrhea and this constant fatigue and being a woman of childbearing age, most likely we're looking at an iron deficiency. And so that's one of the things that are very important, is always to look at the lab values while also trying to understand what type of patient that you have in front of you. Because, most often than not, these questions when they come, USMLE likes to throw all of these symptoms and information, and then you might start to think a zebras when it comes to diseases, but you're supposed to focus on the horses.
Yeah.
So the why as to this patient, as we discussed, patient is constantly tired, has a risk factor, is childbearing age, and so her lab values also show a deficiency.
And one more thing I think I'd like to say also is that iron doesn't really have a way to exit the body. So when the only kind of way that iron will exit the body is through bleeding.
I see.
One of the rare ways, which is not a normal process that usually happens, except for in women of childbearing age.
Yes.
When they have their menses. So, which is why hemochromatosis, for instance, as an alternative is so dangerous, because iron just keeps accumulating and does not exit, right?
Yeah.
In this case, iron is exiting through a way that's normal.
Yeah.
But then you have too much of it with the fact that, she's having heavy menses.
Yeah.
So that's something that's just to keep in mind as we're.
That's a really good point, Dr. Kiran.
Yeah, of course.
So that speaking about your bleeding issues, that's iron leaking, and we kind of want to stop that bleeding altogether.
Of course you would.
So some of the causes for iron deficiency anemia, obviously it's the most common. It's often due to inadequate iron intake because of the diets that individuals choose to have. If they're not eating some meat products, often vegetarians are the ones who are have deficiency in iron. As we discussed, blood loss in pregnancy and menstruation can be a big factor, cause and risk factor for iron deficiency. Internal bleeding, stomach ulcers, colon polyps, cancers. Obviously, older individuals, especially males. Where you start to see iron deficiency, and that you start to think maybe a colonoscopy might be the right choice. Inability to absorb iron to those individuals who may have gastric bypasses, celiac disease, genetic problems can also cause it. Von Willebrand disease, hemophilia, anything that causes any bleeding disorders, and endometriosis, again, going back to the women with heavy menstruations, right? So some of the risk factors, as we were discussing, they correlate with what the causes are: childbearing ages, pregnant females, poor diet, again, vegetarians who are not eating a lot of meat products or not eating the green leaves, infants and children, especially those who are born prematurely because they're, having difficulties getting their nutrients in, teenagers who have a greater need for iron because they're rapidly growing.
Correct.
Right? They need enough they need to eat a lot, just like how infants, they need to be eating a lot of their nutrients, but they often don't get it. And it is a crucial time because they're growing, so their body needs more. Adults over the age of 65, again, that goes back to the diet and could be because of any source of bleeding.
Also, often they have like the tea and toast diet, which we also see with vitamin C deficiency.
Yeah, exactly. And anybody who's exposed to iron in their environment, obviously, because iron chelates off that, the blood and kind of gets rid of the iron. So sorry, I said iron.
That's all right.
Lead gets rid of the iron. So yeah. And high performance or endurance athletes who do marathon runners, because they need a lot of red blood cells, increased production, increased requirement of the supply. Right. Anything to ask in terms of risk factors that I may have missed?
I don't think so. I think they're pretty comprehensive, and I think they very much tie in with the etiology. So I think you did a pretty good job.
Perfect. And so, something over here we can discuss the iron studies, which is something we can use actually if we are unsure if iron is the reasoning behind someone's anemia.
Exactly.
We can order a lab value with iron studies, and we can get values like the iron. We could get information like the serum iron, transferrin or transferrin binding capacities, right? The saturation of it, and ferritin, just the form of the iron itself. Could you go over some of these?
Yeah. So iron studies, basically, you would order these if you're unsure, as you mentioned already, for the case of iron deficiency anemia, if you're really not sure and nothing in the CBC might be pointing to it, but you're really you want to make sure you diagnose. This is actually the way to diagnose, because what the hemoglobin and hematocrit tell us is that there is anemia. Right. Now, there can be many types of microcytic anemia. And so you want to go further into, generally most common cause is iron deficiency, right? So you would go with that safely, but generally speaking, if you want to go further dive into and assure that it is iron deficiency anemia, you can go ahead and do iron studies.
Gotcha.
What do you see in the iron studies? So you want to check how much iron is available in the serum, right? That's one thing. Two is transferrin or TIBC. So what is this? What's transferrin? Transferrin is basically a protein. It's kind of similar to albumin in my mind, where it helps transfer iron from one place to another. Right? Because iron is kind of dangerous, right? It can bind to other things. It can, so you have a transport, basically, protein. So you have TIBC is, and I explained it a little bit in the other slide, but TIBC is basically the capacity of transferrin, or the number of transferrin, if you think about it this way, proteins that can bind to iron. So if you are low on iron, you have many of those protein available to be able to bind iron. Now, if you have too much iron in the body, all of them will be at full capacity. So your capacity will be low.
Gotcha.
Right. But in the case of iron deficiency, you have a greater capacity to bind them because those receptors or those proteins are empty. And they're not bound to iron because your body doesn't have a lot of iron. Ferritin is basically the storage or the stored form of iron. Obviously, in iron deficiency anemia, it's going to be low because you are deficient in that. And then obviously there's a calculation you can do. So transferrin saturation, basically. So serum iron divided by TIBC. And that can give you a kind of at a greater, more calculated perspective, and it's going to be significantly low. If you can compare that, let's say, with hemochromatosis, which is a disease of increased iron in the body or increased storage of iron, right? Because you have a mutation that goes ahead and the receptors kind of continue to sequester more iron, your serum iron will be elevated, your transferrin or your ability to bind transferrin will be low because they're already bound to iron that's in the body, and your ferritin will be extremely elevated. So the exact opposite. So it's a great kind of way to look at the studies, and then you can always compare it with pregnancy, right? And OCP use, right? So in pregnancy, actually, it's very interesting. It shows that your TIBC is elevated, right?
Can you explain as to why in pregnancy that happens?
So if I recall correctly, basically you have increased production of generally proteins and increased binding capacity, but that doesn't mean your serum iron is low. At a baseline, your serum iron is not necessarily low. Also, there is increased, your blood is more dilute. Right. But if there's anything more you want to add to that.
Yeah, you're right. Exactly. In pregnancy, we start to create more proteins, and that's what happens. That's exactly why we have the transference value kind of increase, because we've got more of these proteins, but the overall value of the red blood cells that have iron, we don't have any deficiency.
Exactly.
We just have more proteins.
Yeah.
All right. So yeah, as we probably already discussed in detail how to diagnose somebody with iron deficiency, a lot of it can be clinically aspect and just from the initial lab work. CBC is by far one of the best. You know, you can look at all of the red blood cells, white blood cells can help a little bit, but more for the hemoglobin, hematocrit, the MCV, all of these values can give you an idea of how much red blood cells are there and what their shapes and sizes are. And so low ferritin, high RBC distribution. And so these are some of the things that we look at when we're trying to figure out in terms of CBC. Now, there's something that I always have trouble with. I'm sure others do too, but could you explain to me what like red cell distribution is exactly? Red blood cell distribution?
Yeah, sure. So red blood cell distribution width is basically, you know, as I mentioned here, it's basically a way to assess the variation in sizes of red blood cells.
Okay.
So if a person has decreased iron in their body, it's going to be high. There will be a lot of variation. Normal is usually consistent.
Gotcha.
Right? Normal is usually consistent, but in the case of abnormal, you're going to have high RDW because you don't have proper erythropoiesis. You don't have proper production of red blood cells because there's lack of iron.
So there'll be different shapes.
There'll be different sizes.
Exactly. I see. So that's where the distribution comes. That's interesting.
I always struggle with that too. So
yeah. Well, I'm glad you kind of made it easy for us to understand. So out of all of this, what is a great treatment for somebody with iron deficiency anemia?
Oral iron. So replace iron or orally. So depending on the deficiency, right? So whether it's severe or not so severe, there can also be IV iron, right? Which I think you talked about earlier, who it's given to. You can share more about that. But generally speaking, a person who is low on iron and fatigue and doesn't need to be like hospitalized for iron deficiency and whatnot, they can have, you know, they can consume iron orally. So iron sulfate. Obviously there's side effects with anything, right? So iron can cause constipation, diarrhea, abdominal pain, all of these things. But otherwise, just, you know, generally giving iron can for months, obviously 4 to 6 months, can replenish. You're basically replenishing your storage.
Gotcha. That's what you're doing.
If you want to talk about the IV dextran, so.
Oh yeah, IV dextran is also a situation where you have a individual who, let's say, is very anemic, or in a situation where they are losing a lot of blood cells, and you, especially in a situation where if you have an individual that might have a gastric bypass, right? Those type of individuals is someone you can give an IV dextran to, because you've got to put them on a routine basis, because if you give them orally, they're not going to digest it. It just bypasses it, right? So you basically, for those individuals, you kind of save that treatment. Very rarely I've seen if a situation occurs in the clinical setting where a patient comes in, they have very low iron levels, and you often just say, okay, you know what? Let's just put them on IV because they're so low. And then after the initial IV, we'll get them into a regular oral tablet basis. So those are usually where we go with first, but you know, there are situations where even a normal person might need some IV iron. Right? So yeah, I mean, I think that's basically all of it for today in terms of anemia. It's a very interesting topic. I think it's one that requires a little bit of critical thinking, but lab values will be the most important things. Any last words in terms of what's the best way to kind of understand anemia?
Yeah, I think just as we mentioned earlier, I think you talked about it too, just the MCV. I think it's a very good determinant, mean corpuscular volume, right? There's also things you can see in peripheral blood smear. I know in step 1 they like to test us on that. But MCV is just generally great because you can always organize your information. You know, higher than 100 or less than 80. Or between the two ranges. I think that's one way to go about it. And then I think also focusing on reticulocyte count to know whether it's hemolytic or not, right? So or whether your bone marrow response is normal or not to that anemia. I think that's one thing. But I think on a side note, when you said everything that's close to something that's very close to all of our hearts in the beginning, I thought about you know, the USMLE exam trauma. That's what I was like. I thought you were going to say something different.
No.
Either
Yeah.
that or the island life.
Island life. Yes, yes. Those are all
Not
very close
anemias,
to us,
but hey,
anemias are also very close to us. But again, thank you guys for watching. Please, if you like our content, subscribe and give us a follow. Thank you very much, and best of luck with your studies. Take care.
Bye.
Bye.